Good afternoon, everyone. Myself Ankita. Today I am going to present about molar pregnancy. Uh, Anyone knows what's molar pregnancy? Okay. So let's study about molar pregnancy. It's nothing but the abnormal tissue growth in the uterus. Uh, okay. It's a rare pregnancy disorder characterized by the growth of abnormal tissue inside the uterus instead of a healthy fetus, known as hereditary-form mole. Here, what happens is instead of a healthy fetus, rare grape-like tissues are formed like crystals inside the uterus instead of a healthy fetus. Okay, so it's again divided into two, that is complete molar pregnancy and partial molar pregnancy. In complete molar pregnancy, no fetus is present, only cystic placental tissue develops. And in partial molar pregnancy, some fetal tissue may be present, but it is not viable. Here, in complete molar pregnancy, this occurs when an empty egg is fertilized by one of two sperms. Empty egg in the cells, there will be no maternal DNA. Yeah. And there in the partial molar pregnancy, this result from a normal egg being fertilized by two sperms or a duplicated sperm chromosome. Here, egg will be having the maternal DNA and two sperms. By two sperms, it gets fertilized. Then this partial molar pregnancy may occur. So, complete molar pregnancy is seen more commonly than partial molar pregnancy. So here the possible genotype in complete molar pregnancy is 46XX or 46XY. But in partial molar pregnancy, as we see duplicate sperm chromosome is there, one extra. So here it will be 69XXX or 69XXY. Okay. So going to the causes, what do you think? What may cause it? What may cause? Uh, let's study about the causes. Complete mole formation. It is an empty egg is fertilized by one or two sperm. Only paternal chromosome are duplicated, resulting in an absence of maternal genetic material. As we know now, the maternal DNA is not present in that egg, so only the paternal chromosomes are duplicated. But here in partial molar pregnancy, a normal egg is fertilized by two sperms or duplicated sperm chromosome. This leads to an extra genetic material, typically 69 chromosomes instead of usually 46. As we know about normal human cell, how many chromosomes it has? Actually, it has 46. That's paired like 23 and 23. And in that 22 will be autosomes and one will be sex chromosome, like one pair will be sex chromosome, XX for female and XY for male. That is common, right? But here 69 chromosomes are there instead of 46. Okay, this is so this is a severe genetic abnormality in which the fetus has three complete sets of chromosomes. Okay. So moving to its risk factors. Risk factors are maternal age under 15 or above or over 40. Okay, and previous molar pregnancy. If the patient already had previous molar pregnancy, then can be caused. And nutritional deficiencies can increase the risk. Nutritional deficiencies like vitamin B, if protein is less than, and fat also. So, and if a female, she has given birth twice already, and it is her third birth, then also risk can be there of molar pregnancy. Then watching for symptoms. Vaginal bleeding, initially often dark brown or bright red occurring during the first trimester. Severe nausea and vomiting, exceeding typical pregnancy sickness, often persistent and intense. Rapid uterine growth. Uterus appears larger than expected for the gestational age. And then pelvic discomfort, pelvic pain or pressure, occasionally accompanied by passing grape-like crest. And other indications, early preeclampsia, high blood pressure will be there, then ovarian cyst and hyperthyroidism. This will be due to increase in the HCG levels, okay? Yeah. So the common thing is, if a patient and she skips the menstrual period and has nausea, vomiting and everything, what she will think? Like she will think that she will get pregnant, right? So what she will do in early stages, like she will get a home test kit, pregnancy kit, and then what do you think the outcome will be, like positive or negative? Mm-hmm. I said high HCG will be there. Yeah, ma'am, but she will be having all the symptoms like pregnancy. So it will show positive results. The home kit can't differentiate between molar pregnancy and pregnancy. Okay, so the diagnosis will be uh, ultrasound. As I said, grape-like structures will be formed in your uterus. So ultrasound will be done. Reveals a characteristic snowstorm or cluster of crysts appear in the uterus with an absence or abnormality of the fetus. Okay. Then the blood test. Extremely high levels of human chronic gonadotropin hormone, significantly exceeding those found in a normal pregnancy. Here, it will range around like 1 lakh milli international units per millimeter, the HCG levels. Yeah. And the physical examination, the uterus may feel enlarged and inconsistent with expected date, often accompanied by reported vaginal bleeding. Okay, in the primary stages, vaginal bleeding will be there. And then going to the treatment, okay, risk and complications. So persistent gestational trophoblast neoplasia, molar tissue. This like molar tissue continues to grow even after the initial removal, necessitating further treatment. Like after the treatment is done, that time the risk and complications could be uh, like remainings of abnormal tissue, that further may lead to like further again it may lead to the or carcinoma. This is choriocarcinoma, a rare but aggressive form of cancer that can develop from a molar tissue, though it is highly responsive to chemotherapy. The thing is, choriocarcinoma is a rare, fast-growing cancer originating from trophoblast cells, often in the uterus after molar pregnancy. Only after molar pregnancy you can see this, okay? Choriocarcinoma, it develops in uterus. And then anemia and hemorrhage, common complications, particularly in India Tertiary Care Hospital, requiring immediate medication attention. Okay. Moving to the treatment, surgical evacuation should be done primarily. The main treatment involves dilation and curettage to carefully remove all the abnormal tissues from the uterus. Okay. Then further management, in rare cases, a hysterectomy, that is nothing but removal of the whole uterus, may be considered. Chemotherapy is administered if persistent GTN or malignancy develop. Only if the residues are there, then or else if HCG is very high after the treatment, like after the removal also, then we can go to chemotherapy. In that, if low risk is there. If low HCG rate like that, then methotrexate can be given primarily, or higher risk combination therapy should be done. Yeah, with methotrexate, etoposide, oncovin can be given. Yeah, and then emotional and physiological support, as we know that the woman will be going through too much after this process, so providing comprehensive emotional and physiological support for crucial for women throughout their treatment and recovery journey, should give support like family or friends. Follow-up and prevention. Avoiding pregnancy for at least 6 months to ensure complete recovery and normalize of HCG levels. Then women with prior molar pregnancy have about 1% risk of reoccurrence, necessitating close monitoring in further pregnancy. You should monitor HCG levels, and then regularly HCG monitoring is crucial until levels normalize, confirming no residue disease remains. Okay. Here in India, uh, approximately 1 in 1000 pregnancies in India are affected by the molar pregnancy. Common presentation, like what the patients typically present with absence of menstruation followed by normal abnormal vaginal bleeding. Key complications can be high rate of anemia and acute hemorrhage are frequently observed, highlighting the need for prompt intervention. Successful treatment. Most cases are successfully managed with suction evacuation with early diagnosis and referral significant improvement patient outcomes. So the conclusion, awareness saves life, as we know. Early recognition, molar pregnancy is rare but serious. Early recognition and treatment are vital for positive outcomes. Timely care, understanding symptoms and risk factors empowers timely medical consultation and intervention. Full recovery with proper management, most women recover fully and can experience healthy pregnancies in the future. Spread awareness. Promoting awareness is crucial to protect maternal health and significantly reduce potential complications. Yeah. So, start with MCQs. Uh, Classic ultrasound appearance of molar pregnancy is, yeah, a common presenting symptom of molar pregnancy. After evacuation, HCG levels should be monitored for how many months? The most serious complication of molar pregnancy could be, yeah, first line investigation to complete mole occurs due to what? Yes. Which tumor marker is used for follow-up? Preferred method of evacuation in which molar pregnancy?
Suction evacuation.
Which is not complication of molar pregnancy? Risk of reoccurrence of molar pregnancy is about
1%.
good. The pharmacist role in preventing reoccurrence of molar pregnancy includes the most common type of molar pregnancies.
Common type of
Pandiji. Yeah. Chemotherapy is not required if molar pregnancy when beta HCG levels remain elevated after evacuation. There is evidence of invasion,
This is tricky.
invasion or metastasis. Complete evacuation is done and beta HCG levels return to the normal.
Yeah.
The patient develops theca lutein assist. Thank you.
Our question.
No need. Yeah. Tell.
What is no. See, in complete molar pregnancy, we are seeing that when egg is fertilized by one or two, how it is